Welcome to our program, Tumor Testing and the Transformation of Lung Cancer Treatment. The American Lung Association thanks AstraZeneca, Bristol Myers Squibb, Foundation Medicine, Pfizer, and Merck & Company Incorporated for their generous support of this program. I'm Carly Ornstein, the National Director of Lung Cancer Education at the American Lung Association. During this conversation, I will be joined by Dr. Justin Gainor and Dr. Mark Poole as we discuss lung cancer tumor testing, what it means, and who should be tested. Dr. Justin Gainor is an oncologist and assistant professor of medicine at the Harvard Medical School and Massachusetts General Hospital Cancer Center. Dr. Mark Poole is an attending pathologist at Rush University Medical Center. We're also joined by several Lung Force heroes in the audience, as well as hundreds joining us online. If you're joining us via Facebook Live, you can post your questions in the comments of the feed, and hopefully we can answer a few at the end of our program. We'll try to address any questions we don't get to in future resources, so stay tuned. Let's get started. Thank you, Dr. Gainor and Dr. Poole, for joining us today. So I'd like to start with the definition of some of the terms that we might be discussing today. So Dr. Gainor, can you help us understand what tumor testing is and what it means?
Sure. So broadly speaking, tumor testing refers to doing additional analysis on a tumor in order to help physicians guide the best treatment choices. Importantly, this is typically done on a biopsy specimen or a surgical specimen, so if someone's already had a surgery. So it doesn't necessarily require additional procedures. This is something that has already been obtained if someone's already had a biopsy. And by and large, what we're going to be focusing on throughout much of this discussion is gene testing. And that is, we're looking at the DNA of tumor cells. So DNA is the building blocks of life, the blueprints, and we're looking for changes in the DNA, and we call those mutations. And this is particularly important because we know that certain cancers, and specifically lung cancers, can have genetic mutations that help inform how we actually treat them.
Great. So can you talk a little bit about the different types of mutations and, how they actually work, what's causing the cancer to grow?
Sure. And here I use the analogy of a light switch for my patients. For many of the genes that we're looking at, these are present in normal cells. And when there's a genetic mutation in them, and at specific points, it changes the function of the light switch. So normally these are under control. Turn it on, it tells the cell to grow. If you turn the light switch off, it says stop growing. The problem with these genetic mutations is that the change results in the light switch constantly being on. So it changes the function of that particular gene. And so the cell is constantly being told to grow, grow, grow. Now we can take advantage of that therapeutically by delivering targeted medicines that actually shut off that signal. But it's just like a lock and a key. You have to have the right genetic change and pair it with the right therapy.
Do we know what causes these genetic changes?
That's a really interesting question, and right now we don't. We know that there are some characteristic features of patients who have these particular genetic alterations. And if we focus on those where we have FDA-approved therapies, we know that, by and large, these occur in patients who have never smoked or who have a very light smoking history. And so we don't think that these genetic alterations are actually caused by tobacco exposure. These could just be simply sporadic events. In all of the cells in our bodies, cells have to divide. And when they divide, they have to copy all of the blueprints from 1 to 2. And you can imagine if I had you copy a book, letter by letter, you're going to make mistakes. Most of those mistakes are inconsequential. But every once in a while, you make a mistake in the wrong word, and it changes the meaning of everything entirely. And my sense, even though we don't have direct proof of this yet, is that explains a lot of it. We're actively looking, though, if there are other causes. I would emphasize that we don't believe that these are inherited. So these are not things that are typical outside of exceptional circumstances. These are not things that are passed down from one person to the other when we're speaking about lung cancer
Right.
and some of the genetic changes that we're going to be talking about in lung cancer. In other cancers, certainly, there can be these familial relationships, but the genes that we're going to be talking about in lung cancer generally are not passed down from one person to the other.
Right, that makes sense. So, you know, when we're talking about this tumor testing, which, you know, sometimes we call biomarker testing or genomic testing, you mentioned that, you know, we're looking for these mutations or these changes in the genes. What else can that testing look for?
Right. Well, this field has changed pretty dramatically over the last several years. You know, I use the term targeted therapies, which is trying to pair a genetic change with a targeted pill directed at that gene change. And that was really something that evolved beginning in 2004. That's when we developed the first targeted therapies. In the last 5 to 6 years, there's been a second major paradigm for how we've treated lung cancer, and that's been using immune therapies. And these therapies work very differently than targeted therapies. These drugs are intended to really boost a patient's own immune system and use that to then attack the cancer. Unfortunately, the biomarkers or the predictors that we've had for how those drugs are going to work have been a bit more complicated, and we don't have the silver bullet in terms of predicting those. But to date, the best predictor that we've had is something called PDL1 expression. And essentially, this is a marker on the surface of cancer cells that indicates that those tumor cells are trying to evade your own immune system. And that's another test that has been crucial for oncologists and pathologists alike to do when someone's been diagnosed with lung cancer.
Great, thanks. So, Dr. Poole, you know, you're a pathologist, and I'd like you to speak a little bit about what your role is in this whole tumor testing process.
We take tissue that's removed from some surgical procedure. It could be a biopsy or a surgical resection of the tumor, and then try to look at it visually, do simple things like just measuring the tumor, and then look at it under the microscope to try to look at different attributes of the tumor in order to try to put it in a group of tumors that we know from previous history from other patients how they will behave or how they will respond to certain treatments. One of the most important things that we do now with genetic testing is to determine which is appropriate tissue to send for genetic testing. So not only are we taking the tissue and trying to maximize the information by looking at it under the microscope, but now we're trying to select appropriate areas of the tumor or to determine whether there's even enough tissue to do this testing, and then making sure that it's triaged appropriately.
And, you know, for those of us that don't know exactly what you're looking at under a microscope, can you kind of explain it in layman's terms what you're looking for?
Sure. So generally there's two or three major types of lung cancer. It's not all the same thing. And so we can tell these different types of lung cancer under the microscope. And so we generally look at small cell lung carcinoma, and then another category is non-small cell. And out of those, which are most of the cancers, these are divided into squamous cell carcinomas and adenocarcinomas. And it's adenocarcinomas in particular that we're really interested in relation to molecular testing. However, now with PDL1, like Dr. Gainor was mentioning, we're looking at all the PDL1 expression on all lung cancers, regardless of this histological type. Some of the other things we look at microscopically are the extent of invasion and other attributes, and we kind of lump this into tumor staging. And the tumor staging is what's useful to physicians like Dr. Gainor in terms of what do we do next with this patient? What are the treatment options and so forth?
Great. So Dr. Poole touched on this a little bit, but Dr. Gainor, I was hoping that you could further explain which lung cancer patients should get this type of testing.
It's a good question, and by and large, when we're thinking about using targeted therapies, when we're thinking about using immune therapies, these are usually in the context of people who have metastatic cancer or stage 4 disease.
That means the cancer has spread.
That means the
past
cancer
the
has
lung.
spread outside of the lung.
Okay.
For cancers that are earlier or contained within the lung, our primary therapies are things like surgery and radiation. But when cancers escape outside of the lung, we generally rely on drug therapies. So that's really where these genetic tests and this PDL1 test is most important in that setting.
By drug therapy, do you mean targeted therapies and immunotherapy?
Correct, and even chemotherapy.
And chemotherapy,
right?
okay.
Historically, when we've been treating lung cancer now 15 years ago, when we talked about drug therapy, it was only chemotherapy. Now it actually spans many, many different things. And I think of this as these three big buckets of targeted medicines, immune medicines, and then traditional chemotherapy.
Great. So just to recap, when you have a patient, if the patient has stage 4 lung cancer, which means it's spread past the lungs, and it's non-small cell and non-squamous, those are the patients that you're really looking at to see if they have mutations?
That's correct.
Okay.
According to all of the guidelines, those are the specific patients that were, everyone should be tested in that category.
Okay. And what about patients that don't fit into that category?
Right. So as you're alluding to, that accounts for most lung cancers, but there are people who are outside of that, and it's the guidelines suggest that it also depends on some of the characteristics of the patient, some of the characteristics of the tumor itself. There are also large ongoing efforts in the United States and elsewhere looking at the importance of gene testing for these other tumor types, namely things like squamous cancers. Because what we know is that the gene changes for squamous cancers is very different than non-squamous tumors, and so the frequencies of these genetic changes differ. And so what we're looking for differs depending on how they appear visually underneath the microscope.
So would you say the best thing is for a patient just to talk to their doctor about whether or not they should be
Exactly.
tested?
I think this is something that should just be raised. Is this something that I should have genetic testing for in order to help guide therapy for me?
Great. And so that kind of covers the testing for mutations. What about testing for the PDL1, which you said could be an indicator of how a patient might respond to an immunotherapy drug?
This is something that's really changed in the last 2 years. And now any patient with non-small cell lung cancer should be having advanced, and that is spread outside of the lungs, non-small cell lung cancer should have PDL1 testing at their initial diagnosis.
Great. And then the levels of PDL1 will help indicate treatment, whether or not they might be eligible to be on an immunotherapy drug?
Correct. And
Okay.
and this is something that this field is moving rapidly. And if you would have asked me this question in March 2018, I would have given you a different answer than I am today. So just speaking to how quickly the field is moving.
Right.
And now the paradigm is that if a patient does not have a genetic change, so we're not doing targeted medicines, which is the majority of patients will not get targeted therapy. So for everyone else, all of those patients for the most part are going to be getting immunotherapy, and it's just a matter of whether you're going to add chemotherapy to that or not.
Okay.
So,
Interesting.
and we use this PDL1 score to help gauge whether we need to do that.
Great. Thanks. So Dr. Poole, can you tell us a little bit about the different types of tests that are out there to help reveal if patient has these mutations or biomarkers?
Sure. So there's different levels of testing that can be done. For the last 8 to 10 years, we really only looked at 2 or 3 specific mutations. And the advantage to these was that they could be done relatively quickly, and a lot of different laboratories could do them. The disadvantages were that, number one, these were usually done in a sequential manner. So one test was done, and then another test, and then another. And so that consumed not only time, but also valuable tissue. With small biopsies, sometimes you run out of tissue. I mean, we have to have tissue to make the diagnosis to start with. More recently, there's a different type of testing called next-generation sequencing, in which multiple tests can be done on the tissue at one time. And that's been great because you get all of this information off of one testing period. The downsides are that you get a lot of information in addition to these most common mutations. And so it requires a lot of information support to sort out which are important. And like Dr. Gainor mentioned before, there's some changes that are inconsequential, or we don't really know what information they mean for the patient. The other downside is that they usually take about 2 to 3 weeks, and sometimes the oncologist is seeing the patient before they have all of this information. The PDL1 test is a little bit different. That's a test that we actually do on slides, and we examine microscopically. So we do a procedure called immunohistochemical staining, where we use antibodies that are directed against the PDL1, and then look for the level of expression in the tissue. And then we provide a score so that it's useful for the clinicians to decide, whether anti-PDL1 therapy is appropriate or not.
Great. Okay, so PDL1's treated a little differently because you are kind of staining on a slide for it.
That's correct.
Right. Versus how are the mutations looked at? Like under a microscope a little differently?
Right. These are done, the genetic testing is looking for signals that indicate whether a change is present in the DNA or not. So it's not looked at under the microscope. It's really examined by instruments that detect whether the signals are present or not. And so if the DNA is normal, there would be no signal that the instrument would read. If there is a mutation, a change in the DNA, then a signal would be indicated. And so the instrument and the computer behind the instrument tabulates all of these changes, and the results that you get are basically a list of all of the mutations that may be present. And as we said, some of these may be significant and we know about and can link it up with a current or potential treatment. Some of them are inconsequential, and then some of them we don't really know what the significance is. And so part of the goal of getting as many patients, or ideally all patients, tested is to accumulate this data and then link these patients up with studies and see what these mutations really mean, because some of them may be significant. Also, many of them are in very low frequency, so they're less than 1% of all of the patients that have cancer. So it's difficult to group these patients into similar patients because they're so infrequent. So by testing more and more patients, we develop this database.
Yeah, that makes sense. And in our next panel discussion later this afternoon, I think we're going to be talking a little bit about that and how this data can actually really help move lung cancer research forward.
Right.
So Dr. Gainor, when you get this printout, with everything that a patient has or doesn't have, and a report from the pathologist with their PDL1 levels, what's your next step? How does that impact your treatment? choices for your patient?
So in my mind, it's a combination of things go into the decision making. So typically a patient will come back into the office and we'll review it together. And if there's a genetic change in one of 4 genes, and we call those EGFR, ALK, ROS1, or BRAF, these are genes where if they're in specific places, we have FDA-approved therapies, targeted medicines, and that is very straightforward because we know that targeted therapies are the best therapies for those patients.
And we kind of call those actionable?
Call those actionable.
Okay, because there's a targeted therapy pill that's linked to treat the mutation.
Those specific mutations. Okay. And we have multiple clinical trials where we've compared giving a targeted medicine versus historical chemotherapy for those, for most of those genetic changes, not all, because some of those are so infrequent you can't do those big comparisons. Mm-hmm. But in all of those studies, the targeted therapies have always won versus chemotherapy. They shrink the tumors more commonly, patients feel better, and they have a better side effect profile. So for those, very straightforward, we give targeted therapies. Now, there's a whole another group of gene changes where we know a lot about them. We know that they are activating, meaning that the light switch has changed, it's on, and we know that there are, so far, some effective preliminary drug data. So these are drugs that have not been approved yet. They're in active clinical trials, but the data has been very promising. Mm-hmm. And for that, I would group things like RET or something called MET. Those are examples of where response rates to targeted medicines have been very, very high, but we just don't have the regulatory approvals just yet. And for those patients, I still want to pursue targeted therapy, but what that looks like might be a little different because it might be in the context of a clinical trial. If we don't have a genetic change or we do have a genetic change, it's just not something we can target, we don't have a drug for it, then we start looking at this PDL1 score and we start making a decision of whether we should just do immunotherapy by itself or immunotherapy with chemotherapy. And into that decision making, it's not just the PDL1 score, it's also the patient's preferences, what other medical conditions they have, how old are they, their functional status. A lot goes into that decision making.
Right. So the targeted therapy drugs, I'm sure they each work a little differently based on the type of mutation, but basically they're just targeting the mutation instead of generally killing cancer cells and healthy cells, right?
Correct. They're targeting the mutated protein, right?
Great, okay. So, when should a patient be retested? So let's say the patient, had their tissue tested initially before they started any treatment. When, if ever, is it appropriate for them to have another test?
I think this is a great question, and there are lots of layers to this, so I'd be very interested in your thoughts as well, Dr. Poole. The first question I would ask is, how comprehensive was their initial testing? So if this is someone who had 1 or 2 gene tests and they were negative, that might be someone where you do a more comprehensive panel looking to find whether there are alterations there.
Right, so maybe they were doing what Dr. Poole was saying, maybe it was a few years ago or not, but they just were looking for EGFR or then looking for ALK.
Correct.
Instead of all of the possibilities and some of those mutations now are actionable that weren't actionable
Exactly
before.
right.
Yeah.
Exactly right.
Okay.
And it is a bit sobering that despite us knowing about these gene changes now for a while, and despite seeing the transformative activity of some of these targeted therapies, even some of the most basic genetic changes like EGFR and ALK, rates are not 100%. We would think that's the case, but they're not.
Rates of
testing.
Testing, okay.
Even in the United States, there was a recent paper from last week where showing that ALK testing rates were only 60%. So clearly we need to do better, and that number should be 100%. So I would ask first, did a patient have, how comprehensive was their initial testing? If it wasn't comprehensive, that's something that you might pursue. There are various reasons why they may not have had comprehensive testing. There may not have been enough tumor biopsy material, and so that might be something that there's a conversation about. And we might want to get into, are there other tools to test outside of just looking at the tumor material?
Right, so that's meaning that when they had a biopsy and tissue was taken out of their lung, there wasn't enough to do the testing.
Right, there wasn't enough tumor there.
Okay.
Or it's been exhausted with other tests.
Okay.
But in terms of, say that they've had comprehensive genetic testing, and by and large, if you have one of these genetic changes like EGFR, ALK, ROS, these are mutually exclusive. If you have one, you don't have the other. I think that's something important to note. And those don't really change over time. So those are present in every single cell. The medical term, or the scientific term we think about is these are clonal. They are present, and generally you don't lose those genetic changes. The reason to retest, though, is to see if there are additional genetic changes on top of that.
Okay.
So when patients receive a targeted therapy, say a patient has an EGFR mutation or an ALK rearrangement, when you treat with a targeted therapy, over time, the tumor can develop resistance to that targeted therapy. And commonly, that resistance is through additional genetic changes in the tumor. And so that may be one place where we would want to repeat genetic analysis. We wouldn't go back to the first biopsy, though, because the cancer has changed.
Right.
We would actually want to do another biopsy to see how that tumor has changed. Again, with the thought process being that we can potentially change to a different targeted therapy. We can use that information to guide our decision making.
So they wouldn't change from like EGFR to ALK, but they might change from EGFR to a mutation that indicates resistance to an EGFR drug,
Correct.
right?
Correct.
Okay,
so they can develop another mutation in EGFR.
Okay, another slightly different EGFR mutation.
Correct.
That might mean they'll go on a second type of EGFR targeted therapy.
Correct.
Okay. And then my other question is, if you were tested and did not have any of these mutations, especially the actionable ones, is there any likelihood that you would then develop one of those mutations?
Usually not.
Okay.
So many times we see that there are other genetic changes in those tumors, but most of the time these are mutually exclusive. If you have one, you don't have the other.
Or if you don't have it, you won't have it.
Correct.
Okay.
Now there are some important caveats there, and I'd want Dr. Poole's input too. First, you need to actually make sure that it was a good quality specimen that was actually tested, and you actually have confidence that you were actually testing the tumor, and not just normal cells around that.
Right.
The other thing is, and I think this is going to be a question mark as we start using other forms of gene testing, like testing the blood. So there's a newer technology called circulating tumor DNA, where we actually look for these gene changes not through biopsies, but actually a sample of the blood, and looking for very, very rare quantities of tumor DNA that has been released into the bloodstream. And that's a prime example where just because it's, quote, negative, doesn't mean it's truly not there. It may be that the tumor just isn't releasing the DNA into the bloodstream. So a negative test isn't really negative, it's more non-diagnostic, and it's something that you may want to repeat down the road.
Great. Do you have anything to add, Dr. Poole?
I think the circulating DNA, tumor DNA, has really kind of let us off the hook in some respects, because it's very frustrating to kind of run out of tissue when we want to do these additional tests, especially when the patient's were initially diagnosed a few years ago. We didn't get a complete molecular testing profile done, and they were negative at the time for EGFR ALK. And now they have recurrent disease, and they undergo a biopsy procedure, and so we want to get a diagnosis, we want to get molecular testing, and just either the sample quality is poor, which is what we assess the tissue for, or there's an insufficient quantity of tissue, or there's enough tissue to run some tests, but not all of them. So circulating tumor DNA actually kind of is one way we can get around that and maybe prevent the patient from undergoing a different procedure. But sometimes, when we discuss these patients with the team, it's decided, yes, we want to go ahead and do another biopsy procedure, or maybe pursue, serum testing.
And then what about PDL1 if a patient wasn't tested? I mean, that's fairly new. It's quite possible that you'll be seeing some patients that, weren't tested for that. Can that test kind of be done at any time on the tissue?
Yeah, since that tissue is done on, tissue that's been fixed and processed, we can always go back to tissue that's stored and do that test. It's not uncommon that we get those requests, several times a month to look back in our archives and pull the tissue out and do the test on it.
Mm-hmm.
Yeah, I completely agree. I do think that the utility of that test also depends where someone is in their disease course. Mm-hmm. And I think the going back and doing the testing is very relevant for people who had disease that was confined to the lungs and they had a surgery and then unfortunately the cancer came back. That's a place where really then you would want to test. If somebody, though, was in a situation where the cancer had already escaped the lungs and they've already gotten standard chemotherapy, that's one place where it's less important to do that test. It's very important at the initial diagnosis and less important after chemotherapy. Okay. And the reasons for that are in the clinical trials that were done compared to other forms of chemotherapy after someone's already had chemotherapy, regardless of whether that test is positive or negative, immunotherapy is better than other forms of chemotherapy. Okay. And so in my mind, if the test isn't going to impact what I do, I don't do the test.
Right, that's a good point. So one thing that I did want to touch on, because I've been hearing about it, is tumor mutational burden. Can you define that a little bit and explain what that is?
Sure. It's actually still a term that is in need of a uniform definition, I would argue. But intuitively, it's something where, think about this, that the concept of using immune therapy the central premise of it is that cancers, the more and more genetic mutations that a cancer develops, so the more and more mutations, the more and more it begins to look foreign to the immune system. If it has one mutation, it's pretty close to normal self, but if it's got 200 mutations, it begins to look much more foreign and is therefore more likely to be recognized by the immune system.
And destroyed by the immune system.
And destroyed by the immune system. So at the most simplistic level, it's really the total number of mutations in a particular tumor. Now, there are many different ways to measure this. It depends on the total number of genes you're looking at, so how much DNA you're analyzing, and what the specific mutations that you're actually counting. Right now, we're lumping all mutations into like one bucket, but there are many different types. And so tumor mutation burden, or TMB for short, is really just some way to quantify the total number of mutations in a tumor.
Okay, which might give us information about how that person might respond to immunotherapy?
Correct.
Okay.
So this looks like it's an independent marker from PDL1. So they provide complementary information, and it also is a predictor for responsiveness to immunotherapy. Now, it's a much more complicated one, though, than the standard PDL1 testing that we've talked about.
Yeah.
It requires much more of that bioinformatics support.
Right. So, patient education is important. We want to educate patients about genetic testing, tumor testing, whatever you want to call it, and the availability of targeted therapies and immunotherapies. But really, the physicians and the hospitals need to play a big part in this too. So that patients aren't missed when they come in, especially, patients that really should be tested. So I was hoping that you guys could speak, maybe starting with Dr. Poole, about what you think needs to happen to get this testing done more reflexively on eligible patients when they see the physician.
I think, approaching lung cancer from a multidisciplinary team approach is how you make sure that you have pathways in place so that patients don't get missed. And if they do get missed, or there's pieces of the information that the treating physicians need, that there's communication between the surgeon, the oncologist, the pathologist to obtain enough tissue, to make sure that tissue is appropriately handled, and then to communicate those results in a timely manner so that the oncologist has that information when they see the patient, and there's not delays in terms of seeing the patient but not having all the information you need in formulating a plan. It's also important in that we educate each other.
Dr. Gainor, do you have any thoughts on how to get this done more reflexively?
I agree completely. I think it all boils down to communication. And I do think you'd actually get different answers if you polled 100 pathologists and 100 oncologists about what's the best way to do it reflexively. Mm-hmm. At our institution, we actually don't do it reflexively because the oncology community at my institution actually wants to have some input into kind of what specific testing is going to be done in what order. Okay. But that's not uniform. I think the bottom line is it's important to get the testing done and really have open lines of communication between pathologists, oncologists, surgeons. Cancer is something that can't be addressed by one single specialty. It's really a team, teams that come together, and you really need open lines of communication to do that.
That's what I think Dr. Poole was meaning by multidisciplinary.
Correct.
Lots of different physicians from different specialties all working together and communicating so that the patient actually gets what they need.
Right.
Right. Okay, great. So now we're going to take a few questions from our audience and try and address some that we received online.
I have a question. Nicole Hampton. I'm with my mother, Cindy Hampton, a lung force hero in Milwaukee. My question is, do patients have to be treated at big hospitals to get this type of testing?
Dr. Gainor?
Yeah, so the answer is no. That this is something that should be done regardless of where patients actually are getting treated. Now, the extent of the tumor panels, the gene panels, can vary from institution to institution, but the core genetic changes with FDA-approved therapies, someone should be getting access to that regardless of where they're getting treated.
And do you have any tips for the language that a patient can use to kind of advocate for themselves?
So I think we've tried using some of that language today, which is, I've heard about tumor testing or gene testing, or what is my eligibility for using a targeted medicine. Those are some of the things that I think a patient or a patient's family, it would be wholly appropriate to ask.
And advocating for next generation sequencing, is that the most comprehensive approach?
It's the most comprehensive approach, and at least bringing it up. There may be times, though, where it's more appropriate to do a very rapid test based upon the clinical situation. So I think raising the question and then starting some dialogue about what are the pros and cons of doing that.
Okay, great.
Good morning. I'm Cindy Hampton, Milwaukee, And does insurance cover this testing?
Yeah, so I can take that one as well. In general, insurance does cover genetic testing if it's done for advanced non-small cell lung cancer. This is something that should be standard of care. So regardless of where you're getting care in the United States, this should be a standard, and so as such, it's generally covered by insurance.
Hi, Dr. Renee Matthews, lung cancer advocate. If a patient's never had any testing done, is it ever too late?
I can take that one. Most of the time we can do these tests on tissue that's already been processed and archived, so we can always go back to that. Occasionally there are some tests that require fresh tissue, but for the next generation sequencing, PDL1, generally we can do that on tissue that even if it was obtained years ago.
This is actually a follow-up question I have to that. It seems like one of the difficulties with this is that there needs to be an appropriate amount of tissue taken at the time of the biopsy. But a patient might not know that they have lung cancer at that point, right? And they certainly might not know to ask about tumor testing. Any thoughts on how we can communicate better with the physicians performing the biopsy so that they know that this kind of testing is going to be coming and they should remove an appropriate amount?
I think from our team approach, everyone is aware that we need a certain amount of tissue. We certainly discuss in tumor boards how much tissue is needed, sort of the minimal amount of cells or DNA that's required. The problem is sometimes the tumor is difficult to get to, or the tumor is associated with a lot of necrosis, meaning that the tumor is growing so rapidly that it actually dies, the tumor cells die themselves, and so we need viable live tumor cells in the biopsy material to do this. So sometimes that's a problem too. Just we don't know really what the quality of the tissue will be until we can examine it under the microscope. Also, because of lung cancer screening, a lot more small nodules are being removed with the idea that maybe they are cancerous. And so we still go through the same process of obtaining tissue for molecular testing, for example, just in case it might be a tumor. And so we need to have a dialogue with our labs or with commercial labs that we're sending these tests out to make sure that if it's not tumor, that we don't do testing. And if there is tumor there, we need some kind of quality assurance that we actually are testing the tumor cells and not normal cells, like Dr. Gainor mentioned before.
Mm-hmm. Do you think there will ever be a time when a liquid biopsy, like a blood draw or even saliva, will be able to replace the tissue biopsy from the lung?
I'd say no.
Okay.
Well, at least for the initial diagnostic, biopsy. I view liquid biopsies as really complementary, not a replacement for. Because what you can't get by a liquid biopsy is actually the architecture. What do these cells actually look like? You're just finding the DNA. Mm-hmm. So you can't say, this is a small cell lung cancer, this is a non-small cell, this is a squamous cancer. You can't figure that out from a liquid biopsy. Okay. It's one of the principal limitations of it. And so it can provide complementary information though. So say you already have a diagnosis, but there's insufficient material to do the comprehensive gene testing, you can try to get it via liquid biopsy. Mm-hmm. Or if someone is already on a targeted medicine and is starting to develop resistance, and it's hard to get another biopsy, that's another place where a liquid biopsy would have utility.
And what about, I don't know if this is also considered a liquid biopsy, but taken from their sputum or the mucus in their lungs? You mean
cells that are in the
like coughing up something that will have cells in it that will give us information. Does that have a role?
Sure, we can do molecular testing. If there's enough cells, those kind of samples, we can do additional testing on PDL1 and molecular testing as well. The challenge really is, again, getting enough cells in these samples. Sometimes, we're making diagnoses on a handful of cells and feel fortunate just to be able to say it's cancer or not cancer. But the paradigm is evolving past that, just from saying, yes, there's cancer, no, there's cancer, to yes, there's cancer, and there's these additional markers or mutations and so forth that are very important now in treatment.
Right, this is kind of what we call precision medicine, figuring out not just the type of cancer you have, but as much about your cancer as possible and pairing it with the best treatment possible, right? Okay, great. We're going to take a few questions from our Facebook audience. The first question is, how does a patient know if their tumor has had next generation sequencing or any type of testing?
I think that's a challenge, especially because this information may reside in other places. So, for example, sometimes we have patients referred to our institution and we don't really know what testing they've had previously. So again, it goes back to communicating with the oncologists or surgeons to find out what has been done so far. So we don't reduplicate testing, but also if testing hasn't been done, that we acquire the appropriate tissue.
This is a question for Dr. Gainor. I'm hoping that you can clarify a little bit. We had a question that says, are you saying that immunotherapy doesn't work after chemotherapy?
No.
Okay.
No. So I'm saying it works regardless of whether or not you have that PDL1 score.
If you had chemotherapy first?
Yeah. So that the role of that PDL1 test, really, it's an imperfect predictor. Okay. So if you take 100 people with lung cancer, only about 20% will actually respond to immunotherapy. If you use that PDL1 test, it actually brings it up to about 40%. So it's still not perfect. And so the role of that PDL1 test is really to help you prioritize at what point you use it.
What point to use the chemo?
At what point to use the immunotherapy?
Okay.
And part of this is historic in that it reflected that these drugs were initially approved after chemotherapy, where regardless of whether you had PD-L1 positive or negative, those drugs were better than chemotherapy. So that's why I was saying that after someone's already had chemotherapy, there's less of a need to actually do that testing.
Okay, great. And can you talk a little bit more about the PDL1 levels? What are the ranges and what do the ranges mean?
So this, thankfully, I would say we've gotten some clarity on this point in the last several years. It was very complicated around 2014, 2015, because there are multiple of these immunotherapies, and in each of the different immunotherapies would use a different cutoff. Even the same drug would use a different cutoff whether someone had chemotherapy or not. So, but fortunately there have been major efforts, collaborative efforts between industry, academics, and industry partners trying to kind of harmonize those efforts and looking at how closely, if you did one PD-L1 test, does it replicate another one? So, long story short, I think the most clinically relevant cutoff is 50%. So 50% of tumor cells expressing PD-L1.
Would that be considered a high level?
That'd be considered high.
Okay.
So yeah, if the tumor is less than 1% expressing, so the tumor cells less than 1% show this positive PD-L1 reaction on the stain, we would call that negative. And as Dr. Gainor said, if it's more than 50%, we would call that a high expression. And so anything in between 1 and 49%, we call that low expression. And so we give that information. It's not just positive or negative, it's really whether it's high, low, or negative.
And depending on that score impacts whether or not maybe they go on immunotherapy before or after chemotherapy.
Yeah,
It's complicated.
Yeah, so and the bottom line now, because these drugs were initially all explored second line, meaning after someone had already received chemotherapy. Once the drugs were approved there, then they started being looked at first line. And so the most relevant thing now is in someone who's newly diagnosed, they haven't received any therapy, it's going to be immunotherapy plus or minus chemotherapy.
Got it, plus or minus chemotherapy. Yeah. Great. One more question. We've talked a little bit about clinical trials. When might a clinical trial be the right choice for a patient? Specifically around this issue of tumor testing and immunotherapy and things like that.
Well, maybe I'll weigh in. I am a clinical trialist. That's a lot of what I do, and I would say that, it depends. And a lot of people have strong feelings when they hear a clinical trial, thinking that it's just because I've exhausted other options, and I want to emphasize that that is not the case. Even things like phase 1 studies right now may be the most appropriate thing to even start with. We've been fortunate in the lung cancer world where we now have multiple drugs that have been approved on the basis of a phase 1 study. Okay, so phase 1 studies historically were just about dose. But as you start using very targeted precision therapies, so you have a biomarker, a test that can identify a group most likely to respond, and a very targeted medicine, you can see dramatic activity even in that phase 1 study. And so now the trend with all of these targeted therapies is that we're seeing activity in the phase 1. And so if someone has one of these genetic changes that is actionable, where we know a lot about it, but it's not approved yet, I would argue that for those people, depending on what the target is, sometimes a clinical trial may actually be the most appropriate very first therapy. It really depends. And this speaks to the fact that sometimes the regulatory aspects, so getting a drug approved, commonly lags behind the science. And so we may know a lot about it. A classic example right now is RET. So this is found in 1 to 2% of people with lung cancer. And we now have several drugs that have shown responses above 70%, so marked shrinkage. But those drugs aren't approved yet. So if I saw a patient with a RET rearrangement right now, I would put them on a phase 1 clinical trial because the current data has been so promising.
Great. Do you have anything to add?
No, I get these reports myself, and I'm always curious to look at them. Mainly, if it's one of the big 4 mutations, fine. But I'm always interested to see these additional mutations for which there's phase 1 trials, and then that kind of triggers me to start looking in the literature and see, are there mutation-specific antibodies that might, that we could maybe do faster, or what are some other techniques, because these are going to be escalated once they're approved and so forth. So I agree with Dr. Gainor. It's a whole new world opening up.
Great. Well, thank you so much for your time today, both of you. A recording of this video, as well as additional resources, will be made available at lung.org/tumor-testing-videos, and that'll be available in the next couple of weeks. If you're tuning in live, we'll have another panel discussion with Dr. Gainor, and we'll also be joined by Dr. Sherry Millis from Foundation Medicine, and we'll be discussing a little bit more about the future of this very fast-paced field. That discussion is going to happen at 2 p.m. Eastern, 1 p.m. Central. So I wanted to thank again AstraZeneca, Bristol Myers Squibb, Foundation Medicine, Pfizer, and Merck & Company Incorporated for their generous support of this program. Thank you.